Hi everyone, this is Neel Raithatha, consultant audiologist and director of Clearwax. Thank you for joining me in my latest video using the iClearScope endoscope. And here we have a patient who attended with extremely sensitive ears, in particular their right ear. Now they've been coming to me for the last 4 or 5 years and they have to attend every 8 months, believe it or not, to have their earwax cleaned. And on every occasion, the right ear always poses a problem, not only because they've got very sensitive ears, but the consistency of the wax in their right ear is very mushy, particularly laterally near the outer half. Now, in comparison, their left ear is what you're seeing on screen at the moment. Although it's softish, it's firm enough to hold together, so I'm able to remove this in one big block, and you'll see that just in a moment. I immediately put some olive oil spray into the ear just to help bind this wax together to make it a bit easier to remove. And I'm just separating it from the anterior canal wall there, but now I'm going to go to the posterior canal wall. There's a few hairs just in the way. You might see one just obscuring the view slightly of the endoscope. And I'm going to begin now separating this from the back part and the lower section of the ear canal to mobilize it, and then it will eventually come away. So I'm just lifting up. Now doing this in their right ear was a lot more challenging because even though I was near the entrance of their right ear and I wasn't making contact with the ear canal, every time I went into that region, the patient thought I was stabbing their eardrum, although I played the video back. And it's a normal thing with this patient, so because they've got such sensitive ears, they get that sensation. And I always just reassure them. And the patient themselves know that I'm not poking the eardrum, but it's always good just to play it back to reassure them. And it then helps with the rest of the procedure. So I'm just removing this plug. It's quite large. Unfortunately, I didn't get time to take a still image. I'm just wriggling it through the first bend, and there we are. So we're just going to re-enter. Got a nice healthy eardrum. Just a bit of soft wax past the second bend on the left-hand side. So I'm just going to use the right correct just to gently scoot this away. And then we'll move on to their more difficult and challenging right ear. So just going to enter the quite a bendy entrance to the ear, and you can probably tell immediately the difference in consistency. This is just probably the most trickiest consistency to remove because it's hard to microsuction, and I do use the correct, you'll see that in a moment, and although I was able to get quite a lot out, it wasn't taking this away in a plug, so then I reverted back to microsuction. And that was one of the occasions the patient experienced a bit of pain, although you can see we weren't making contact with the canal wall. We're probably 2 centimetres away from the eardrum, so it just came out the ear. I just put some more drops in. And with this kind of plug, you can see the indentations made by the tip of the suction probe. It's sort of vacuuming it, it's just pushing into it. It's almost like a soft butter. So I think this is where I'm going to use the correct. Sometimes with this type of wax, and it was actually the case in this ear, the outer half is quite soft, but the inner half is a bit firmer. So if you can get in and behind, you can leverage out the firmer wax, and as you do, it takes away the softer wax. So you've got a sizable piece there. So I would describe this consistency of wax as being a type 6. So back last year, I think it was almost a year ago, back in last February, I was updating my Clearwax theoretical training course, and I decided to modify the Bristol stool chart and make it relevant to the consistency of earwax, because you do get different types of consistency of earwax. And I also did a grading system, how blocked one's ear is. So in terms of the modified Bristol Cerumen chart, type 1 is your kind of the hardest, rock solid, driest type of wax. So that could be comparable to really hard stool. And type 7 is your really wet, loose type of stool and wax, and a soft but firm consistency. So a bit like their left ear, you probably grade that a type 4 or well, maybe a type 5. Oh, I would say type 4 actually, where it came away in a big plug. But here, we just have to, there's a thin layer of skin surrounding this, and we're going to have to separate it. Now, because I've been treating this patient for many years, I kind of know, well, hopefully I do, how to approach it. Now, I'm trying to deliberately avoid the posterior canal wall because that's the part where it's most sensitive, but I am eventually going to have to work in that area. But when a patient comes to you, the main concern that they have is that they can't hear. So first and foremost, what I want to do is try to improve their hearing. Now, although I've removed quite a lot of wax already, at this stage, I haven't noticed any improvement in the hearing because the canal is still fully occluded. So I'm working more on the centre part of the canal and to the right. Here we have to be careful because I'm trying to lift this off the canal wall, but we don't want to poke the canal wall. I think in a moment, the patient again found it quite sensitive when I was just peeling some wax off the anterior canal wall. And I'm approaching with really with a lot of care and attention there because I just don't know how thick this layer is. I don't know where the inferior canal wall is, so I was just hovering over that because if I poke too much, I'm going to bump straight into their bony canal wall and it's going to be really uncomfortable. Again, I'm going straight ahead. I don't know how the thick this layer is at this stage. We don't know where the eardrum is, but I've got an idea now. You can see there's a thick layer of wax and skin very deep in the ear, so I know the eardrum is just behind that. So I'm just going to the back part of the ear canal here. So this is where we're going to be really sensitive. Now, our ears are full of nerves. There's 3 main nerves that innervate the ear canal. On the front part of the ear canal, you've got the auriculotemporal nerve, which is a branch of the mandibular nerve and the trigeminal nerve. The bottom left part of the ear canal, that's the Arnold's nerve, which is a branch of the vagus nerve. And the top back part of the ear canal is the facial nerve. So even when you're removing wax and it's healing away from the ear canal, so you're not actually making contact with the ear canal, patients with sensitive nerves or hyperactive nerves can feel that sensation. So I've just put a bit more drops in. Again, I'm just going to be very careful because I don't know exactly where the floor of the ear canal is there. I've got some indication because I can see the ear canal to the right. But if I push this in even 0.5 millimetre too much, we're going to make direct contact. So I'm just hovering over. I want the suction to do the work. I want to just see if I can lift it. Now, you can see half the ear canal I've got clear. On the left-hand side, we've got all that soft wax still. But I'm okay with that at the moment. I just want to see if I can reveal their eardrum. Again, just going to the midsection. So we're kind of in the centre part of the ear canal still. And now that I've got a bit of purchase, I'm peeling back towards the back part of the ear canal. So instead of starting from the back part of the ear canal, I'm starting from the middle and coming away towards the left. And you can see what I mean by a butter-like or mashed potato-like consistency. It's just spreading this wax across the floor of the ear canal. So with this patient, I do adopt quite a secure brace. With the endoscope, we have a brace anyway. And normally with my holding hand, so my dominant hand, I don't really have a brace there because I feel like it gives me more maneuverability. So having one brace is more than enough because if the patient moves, you're going to keep that patient steady. But here I just felt more secure myself just having a brace with my instrument hand as well. Just, it did restrict some of the manoeuvrability, but because this patient was quite anxious, I just felt more secure myself on this occasion doing that. Again, I'm peeling backwards. Typically when you're cleaning off the canal wall, you start from the lateral parts nearest to you and you go towards, but here I feel like if I come to the centre and peel back, it's just going to be more comfortable for the patient. And every time I'm suctioning, I'm coming into the middle. But you can see there's a horrible consistency here. But still can't see the eardrum. Therefore, this patient's still hearing exactly as they were when they first attended, although we've got a tremendous amount of wax out already. It's not really benefited their hearing as yet. I'm trying to lift up, but I'm keeping my distance as well. I'm just hovering. And you can see a bit of thick and dead skin at the bottom of this plug. Even I'm really approaching with care and caution here. I feel like I was not making too much progress anymore in this area, so I decided to go back to the back part of the ear canal. But again, the patient just found it a bit sensitive, so I'm just going to come out. Now, there's a bit at the top there that's revealing itself, so let's see if I go in that region. So I'm just trying to peel some of this skin at the roof of the ear canal. Just put a bit more drops in. I think I used sodium bicarbonate on this occasion. Previously I was using olive oil. So I'm hoping, because I've cleared a lot of the canal Oadby, that this drops is going to penetrate a bit deeper in the ear. And it did exactly that. It was able to seep in and behind this wax. And once more, I'm just trying to let the suction do the job. I'm not trying to move the sucker too much. And because I've got a brace with my instrument hand as well, there's just a bit more reduced manoeuvrability, so I just want to keep it as steady as possible and without wriggling it too much, which is normally when I remove wax, I'm manipulating the wax and manoeuvring it quite a lot, but here it's going to take a different approach. So again, just hovering over, trying to keep that still as possible and slowly just coming away. Again, I just want to kiss the surface. If I apply too much pressure, it's going to push it further in. It's going to embed into the soft wax and manage to get this away. So now the patient's experiencing an improvement with their hearing, because you can see half their eardrum. But importantly, all the wax is off the eardrum now. So I'm less concerned and worried now, because as well as making contact with the back part of the ear canal, I was worried that I'll push up against their eardrum directly, but now we know the wax is away. I can relax just a tad. And again, I'm going to peel backwards now to the back part of the ear canal. So when you're removing wax, you can do it the normal way is trying to, if you're having to peel wax and go towards the eardrum, you start laterally near the entrance and you work your way to the eardrum. But here I was doing it the other way. I was trying to just alleviate the patient with the symptoms. So even if I couldn't remove the wax at the back part of the ear canal, at least they could hear, and that's the main reason why they came. So that's the patient's eardrum. Well, I hope you enjoyed that video, guys. Take care, keep well, and speak soon. Bye.